EAU in London. What a great meeting this is, Renu.
Yeah, always a great meeting, and especially this one.
Okay, so of course, we're actually still here in Melbourne recording this podcast, but we're dropping this podcast literally at the moment that our colleague James Buteau, who you'll meet again in a moment, has stood off the stage in the main plenary at the EAU, having presented the results of the primary 2 trial and the associated paper in Lancet Oncology, and that is all under embargo. So we pre-recorded the podcast a few days before you're all listening and watching to this, so we're kind of pretending we're there. Well, actually, we will be in Europe, in London for that meeting anyway. So yeah, so it's exciting, isn't it?
Very exciting. Long-awaited trial. It's great that it's in the Practice-Changing Plenary at EAU.
And we do love when we get the chance to do a podcast like hot off the press on a big paper that comes out at EAU. We did a few last year, didn't we?
Yeah, we did a couple last year.
Yeah, so it's really good. So thanks again to everybody for tuning in and listening to this. And if you're interested in primary 2, what you're going to get in this podcast is a really good overview from James Buteau, first author, and senior author, Louise Emmett, another friend of the podcast who's joining us from Sydney, who will be in the audience, of course, in London as well. Louise, we'll come back to you in a second, and then we're going to have a good discussion about it. But I suppose we should welcome James properly first, shouldn't we? So James, you're a friend of the podcast. You've been on many times over the years, nuclear medicine physician at Peter Mac, and your PhD is the primary 2 trial is a significant part of that.
It's the final chapter.
Is it
3
really?
of 3?
Excellent.
Wow. So there's a big baby to deliver.
Yeah, it is. No, thank you for having me here. And it's really fantastic to see like the fruit of 5-6 years of work, essentially since I arrived in Melbourne and started working on primary 1 with Louise. So it's just beautiful to see like another gigantic Australian academic trial reading out.
Awesome. And Louise, the primary trial, which we'll get to in a moment, was your baby and led to this, the Offspring Primary 2 randomized control trial. A proud moment to see it reading out at a big session like this at the EAU with a big publication.
Oh, it's fantastic, isn't it? I'm so proud of what we've been able to achieve as a team, really, across Australia on a shoestring budget, really. I mean, I remember talking to you about this a couple of years ago, Declan, on this podcast. We were talking about primary 2. And we called it a brave trial. And it really was a brave trial. So, congratulations to everyone.
I remember that. Yeah, I remember that, Renu, because we did a podcast. I think Dan Moon was in the studio, was he? And it was to, say, okay, this trial is just opening. And Louise described it as a brave trial, meaning that it might not be successful. It might not have a positive endpoint. It might just, So yeah, congratulations, and it's great to hear that.
But were you surprised, Louise? I mean, especially after primary 1. I mean, you got a lot of information from primary 1 that kind of, and so it seemed, for me, it seems to make sense that primary 2 is going to show something, because we learned a lot from primary 1 outside of the main endpoints of the trial.
We did, but James is going to go into the details of the trial. But when you think about it, you halve biopsies. Not only do you halve the number of biopsies, but then you actually only do targeted biopsies. You don't do systematic or template biopsies, and you expect to see the same number of cancers. So I think that's brave.
So before we get James to give us the overview, kind of a quick summary of what he presented at the EAU in London today, and of course the links are in the show notes to the full paper and to some of the coverage. We'll update the coverage in the show notes as the media releases come out. Renu, we thought we'd just go back a bit because, of course, here in Australia, as people probably know, we've been doing PSMA PET CT for initial staging of prostate cancer for like 13 years now. 2014 is when we first started seeing these amazing scans. You remember?
Yeah, it was incredible, wasn't it? We sort of really haven't looked back since then. It's been kind of one, hurdle after hurdle that we've managed to cross with PSMA PET CT, and the images are so impressive, and we continue to see the relevance of that in clinical practice.
And of course, it was initially the idea that this is very accurate for staging, this whole body scan. And even then, as we set up the proPSMA trial, which was about 2015 or 2016, which published in 2020 in the Lancet, which confirmed that PSMA PET CT was superior to CT and bone scan for accuracy. So that was about staging. But I remember, from 2015, 16, 17, we were noticing that inside the prostate, not just the whole staging scan, but within the prostate, we were getting really interesting information about the location and extent of disease. How does that compare to an MRI? Which I suppose is what triggered the journey to today, to the primary 2 trial.
Yeah, and it's always, we were talking about this before, Declan. we already do this. So it's great to have a trial that stands what we're sort of already doing in clinical practice a little bit in Australia.
Yeah, exactly right. Because just to reflect on our journey towards it, of course, MRI back in 2015, 16, 17, 18 was also emerging, of course, as a key tool for the triage in early detection. And I remember it was kind of when the Precision trial read out in 2018 at the EAU. Actually, I remember it was in the Practice-Changing Plenary. Viru Kazi-Viswanathan read it out, and I was the discussant on that, and it was a simultaneous publication. But we were 4 years into the PSMA era, and of course, everyone was saying you must do an MRI, and if the MRI is normal, loads of people don't need a biopsy. But there was that persisting, uncomfortable feeling for many urologists. Well, I'm not sure. We're kind of putting a lot of confidence into MRI, and we know MRI won't find everything. So I suppose, Louise, that was part of the journey towards the primary trial, wasn't it? The recognition that, well, okay, MRI is very good, but it's not perfect. So do you want to tell us a bit about how you got that journey to setting up the primary trial? Links again in the show notes, but that was published in European Urology 2022. It won Best Scientific Paper of the Year. Just remind us a bit about that and why that became important for today's presentation.
I think what's interesting with PSMA is that the receptor itself is overexpressed in more aggressive cancer cell types. So when you think of it for diagnosis, that actually fits really nicely. And some of the early work showed that you could separate pattern 3 from pattern 4 really nicely. So 18% sensitivity with pattern 3, 90% sensitivity for pattern 4. So it was really a logical step, I think, to move PSMA PET into the diagnostic space for those difficult MRIs. I guess that's what we're really thinking. And what Primary did was it took all men, all PIRADS, who had an MRI and were going for a template biopsy, and just slotted in a pelvic-only PSMA PET in between those two, and showed really nicely that PSMA PET had a lot of potential in this space to identify clinically significant cancer. So fantastic to see us moving the next step and seeing whether we can actually change management and outcome using it as a tool for the diagnosis of prostate cancer with MRI.
And Renu, one of the important things that came out of that, which is really important for the Primary 2 trial, was the development of the primary score. That was one of James's big babies, I suppose, throughout all that time. We were just getting the hang of the PIRADS score, and then we had to learn a new score.
Yeah, but so important, isn't it, for standardizing reporting and making sure that everyone knows what you're talking about when we're talking about expression on PSMA PET.
Maybe we should ask James a bit about that, because that's also very prominent in today's paper. James is the role of the validated and how did you get to the primary score?
Yeah, no, thanks. The primary score, led by Louise, and we put in a lot of work with Nathan Papa also. So I think when I arrived at the time, it had just been a year or two that we were in Melbourne, and I ended up reading and rereading all of these scans way too many times. And we did notice that it's not all about the SUV max, but also about the patterns, which parts of the prostate are lighting up. Is it the central zone or symmetric normal patterns like the central zone, transition zone, that we can be confident are a very low likelihood of cancer versus anything that's focal. So I think we initially developed that, especially with, like I said, Nathan and Louise, then started validating in other cohorts. And now it's integrated in lots of guidelines. We've seen it coming out in Spark.
EAU,
Promise.
Spark, yeah.
Yeah, so it's been, very proud of that initial work also. I remember, so many MDMs also. I've noticed that you've both become experts in the primary score. I'll throw those at Declan and Renu and ask what they think about it. And they're quite good nuclear urologists now.
That's what he does, Louise. In the MDTs, he's constantly saying he'll put up a scan, okay, blah, and he'll say, Declan, what's the primary score? So I have to be on my toes.
Yeah.
Do you do that in Sydney? You got James Thompson, having to actually read the scan?
No, it's not so exciting actually,
You
but
should do that.
that would be good. Declan, I'm going to have to plug my computer in, so I'm just going to move, and you'll just have to. Can you mind cutting this bit?
No problem. You do that. So look, I suppose should we get James Renu to have a chat about the actual what he presented today? Yeah, should we do that? So the background was the primary score. The primary paper showed us that there is value in doing a PSMA PET CT before a biopsy, but in particular, You know, the patients with the normal or equivocal MRI scans, that's where the sweet spot was. You know, PIRADS 4/5s, you know, it's nearly always right, or it is. But what about the PIRADS 2 or the PIRADS 3 in the patient who has like a clinical suspicion, like for example, a high PSA density, or there's a BRCA mutation? You know, there's a reason why we're a bit uncomfortable about the normal MRI or the kind of wishy-washy PIRADS 3. So that was your patient population, wasn't it? And so I suppose let's tell us a bit about that, and then about the design of the trial, because of course it's a randomized trial. So over to you. You can, I suppose, give us a little run through of what you talked about today.
Yeah, no, I think from primary we learned which primary looked at PIRADS 2 to 5, and I think we really saw where the money is PIRADS 2 and 3. Like half of the patients had that kind of normal or equivocal scans. We did learn, I think, that it's a lot more common to have significant prostate cancer than we expected in these triage men, where you have this lingering or high clinical risk that warrants further biopsy. So in this trial, we designed, basically it's focused on PIRADS 2 and 3. We knew that from primary 1, we avoided about 40% of biopsy in patients, and there were about 30 who had significant prostate cancer, grade group 2 or higher. So in this trial, it was randomized controlled, 7 sites across Australia. We even got sites up in Darwin running, Brisbane, I guess pretty much across all states. And we randomized in a 1-to-1 ratio either to have the control, so a template biopsy, versus the PSMA PET. I guess the interesting part is the PET can help in 2 ways. One, it can really help triage, and if it's normal, altogether avoid the biopsy and keep an eye on those patients without an immediate intervention with biopsy. And when it lights up, it's very clear. So you've seen them in MDMs. So we can really help guide where to go for biopsy instead of going blindly throughout and trying to get little samples everywhere.
Yeah, and so having recruited very many of the patients in this trial, it was a really interesting process for us urologists. The many urologists around on the trial, many of whom were in the audience actually in London today. So I'll give you just like the typical patient for me. It's not going to be a 68-year-old with a PSA of 4. And a 60 cc prostate, they're not eligible for the trial because, okay, they're fine. They've got a normal MRI and so on. It's the patient who is, let's say, 60, but he's got a 30 cc prostate, but his PSA is 12 or something like that. So he's got a very high PSA density. He's got a normal MRI. And so those are the patients that, even within guidelines, we traditionally will not just reassure and say, go away, we're going to do a transperineal prostate. Well, we always do transperineal in Australia. Do a systematic biopsy because we're worried that patient, will have occult disease not visible on MR. Yeah. So hence the control arm. We, as urologists in this trial, we felt very comfortable, I think, recruiting those patients, Renu, and saying to the patients, well, look, we recommend a prostate biopsy here, but we're going to sample the entire prostate. But on the other hand, we know from the primary trial that, of course, many of those men will have no cancer at all, or will have grade group 1 cancer. And I suppose that's okay. We can just do surveillance, but still it's an unnecessary kind of diagnosis. So the argument then for us to say to the patients, because the equipoise to be able to say, there's a 50-50 chance you'll either have a biopsy or you'll go into the fancy arm where you get the PET scan, and then it depends on what the PET scan is. That's a complicated enough conversation. We got good at it after about 650 patients in the trial, I suppose. But it can be a hard sell. I think we did see a little bit more dropout in the control arm, like 35, so about 11% versus 2 in the PSMA PET arm. And I think that we did notice that the consent is very important, but regardless, patients just want that PSMA PET scan. I think that population is right. It was about 60, a median of 60 years old. About half had PIRADS 2, half PIRADS 3. And the PSA density was greater than 1 in about 3/4 of them. Strong family history in 20%. So they were not the garden variety PIRADS 2, but really that higher risk. We think that PSMA PET was helpful for. Yeah. Before we dive into it, what are your comments on that patient population, recruiting patients in this trial?
Yeah, I mean, in some ways, James, you're right. It is a hard sell, but you kind of, knowing how PSMA PET performs in this setting, it was quite easy to recommend this to patients. So I think recruitment would have been actually fairly straightforward.
Except for those, as you say, going,
more for the country.
I was hoping I get the PET scan, but then we have to reassure them to say, look,
this is standard
an
of
experiment.
care.
Yeah, exactly. The reason we have to do a trial is, probably the safest thing to do is do a biopsy. That's what all the guidelines say.
Yeah. No, I think it's mainly around the PSMA PET. Everyone wants that, so I think the randomized control.
Very good. So that was it. 650 patients, and we recruited, and then they were randomized to either have a biopsy, and then they came back to their original urologist and had a biopsy. Or you guys and girls around the country running the PET side of this fantastic trial did a PSMA PET CT of just the prostate only.
Yeah, exactly. So relatively low chance of having cancer. So I think to reduce the radiation to the general population, only concentrated on the pelvis. And if ever there was something that was high risk, extend to whole body for staging.
Like if you see a big obvious tumor or a lymph node or something.
Primary score of 5.
5.
That was it.
That worked out pretty well though, right? So when we look at the number of patients who actually needed the whole body or who had identification of lymph nodes or, the idea of metastatic disease, it was really low. So I think doing a pelvic only PET in this group was a good choice.
Yeah, and then you've got the convenience though. Instantly someone's looking at it to say, okay, well, we have the PSMA on board. It's very easy to extend to a whole body scan instead of having to do that after the biopsy and so on. And then and tell us about the endpoint, James, about the primary endpoint in the trial.
Yeah, so we had co-primary endpoints. The first one was around significant prostate cancer, which was defined as grade group 3+4 with greater or equal 10% of the pattern 4. And the other one was around biopsy avoidance. So those in the PSMA PET arm, how many would avoid biopsy? We expected roughly 40% based on primary 1. So we powered for that endpoint. We had a non-inferiority margin of 10% for the primary endpoint around clinically significant prostate cancer. And the key secondary endpoint was really around insignificant prostate cancer, which included the grade group 1, but also when you had less than 10% of pattern 4.
And then the hypothesis was that you would have the same pickup rate of clinically significant cancer in both arms, even though in one arm everybody got a saturation or systematic biopsy, and in the other arm, probably only half the patients are getting a biopsy at all, and it's only going to be targeted cores. It was targeted only cores we were doing, but even then the idea was that we're going to have the same pickup rate of significant cancer. So that's what you meant, Louise, when you said, it's a kind of as a brave trial to go for that type of an endpoint. Yeah,
that's right. Exactly. A brave trial. So you technically halve the number of biopsies, but expect to pick up the same number of clinically significant malignancies. So brave.
Well, Renu, I suppose then to the results. Having established that, and tell us what did you report today?
Yeah, so for the first co-primary endpoint, we had 16% of significant prostate cancer in the control arm versus 12 in the PSMA PET arm. So it was a difference of minus 3.7%. So it was significant, non-inferior to the control. And we avoided 49% of biopsies, which was also significant. We had powered for at least 20% avoidance. I think it was a double win.
Yeah.
Essentially, and the other key one is around insignificant prostate cancer. So those who went on for biopsy, there were 32% with insignificant prostate cancer in the control. That dropped down to only 14% in the PSMA PET arm. So essentially, we can use PSMA PET to avoid biopsy in half of the men, reduce insignificant prostate cancer without compromising the diagnosis of significant prostate cancer, the one you really want to know about.
Gee, Renu,
ideal situation.
There's a few wins in there, aren't there?
Yeah, for sure. I mean, that's amazing.
Yeah. Obviously, that main endpoint of the pickup rate of significant cancer is the same, even though only half the men have a biopsy, and even then they're only having targeted biopsies. I mean, for us practicing urologists, that's really reassuring, isn't it? And for
absolutely.
I think.
Yeah, sorry, Louise.
I was going to say the other thing that I think was really reassuring about that was, it was within the non-inferiority margin, but when you look at the high-grade cancers, they were very similar. So the detection of high-grade cancers, most of the difference was actually in the ISUP2s.
Very good.
Yeah, it's that group of people that really are a bit of a conundrum clinically.
And Renu, what do you think of the fact that the clinically insignificant cancers dropped from, what did you say, 32% to 14%?
Pick up rate, yeah.
So a difference of 18
So
it just goes to show, MRI has been such a game changer for us in the last 2 decades, and we can improve things even more.
Because one of the big attractions of MR out of the precision study, and Vera is one of our co-authors on this actually as well, one of the key attractions of the precision study was that it showed you could really cull the proportion of insignificant cancers. I think it was from 23% to 9%. And it's quite a similar study design. That's important. And then this trial goes on top of that again to say, even with an MRI triaged population, the normal MRIs, that you can further reduce the insignificant cancer pickup rate. I think this is a really important part of the trial.
So Louise, where to from here? What are the implications of this trial on clinical practice?
So I'm super interested in getting your opinion on that. But for me, one of the big things of this trial wasn't just that we're going to halve the biopsies, but that we halved the amount of insignificant malignancies that we pick up. Because, of course, I don't know what you think of active surveillance, but there's a lot of men who get very anxious about active surveillance. And I have a family member who couldn't deal with it and ended up having a radical prostatectomy for very low-grade cancer. And so what do you think about the fact that we can halve the amount of insignificant malignancies that we pick up in these men who really have a low incidence of significant malignancy but get a biopsy?
All we have to do, Renu, I think, is go back and think about that episode on renaming Gleason 6 prostate cancer with Scott Eggener and Matt Cooperberg a few months ago, which was kind of an encore episode. It's a really important topic to try and avoid these type of diagnoses.
I think we overall, we're very good at active surveillance, especially in Australia. I think we're good at counselling patients about what to do with insignificant prostate cancer. But you're right, Louise, it causes patients a lot of anxiety, and you're giving them essentially a cancer passport. And you're labeling them as cancer patients. And as they go out into the world and they hear multiple sources of information, that feeds their anxiety. And there are still some clinicians around the world who are anxious about it. So, I think it takes a very difficult problem and gives us at least a part solution to it. So I think it's great, even though we are getting better at managing low-risk disease with active surveillance.
So James and Jochen...
Sorry, Louise, I was just going to say.
So are you going to use PSMA PET in this fashion now that you've got this information? Are you going to use it to avoid biopsy in these patients?
Absolutely.
Yeah, and the thing is, since the trial finished... we
were just waiting.
Yeah, the trial finished was it October? We had the last patient in. So now we don't have the trial. We've been used to having it for 3 years, so it was ideal for these patients. And now, we don't have the trial, so we're still having the discussion. And after today's paper and publicity, it'll be like patients will be even more aware, but it's not funded. It's still not funded. After proPSMA, it took a couple of years before funding kicked in. But in Australia, PSMA PET is very good value, and a lot of patients will be prepared to spend a few $100s on these scans. So the answer to your question, Louise, is from a clinical practice point of view, absolutely. The trial has shown us that this pathway for this group of patients with a normal or equivocal MRI who've got clinical suspicion, this has shown us that you can offer the patient a transperineal biopsy, all the patients, and they're going to have a 30% pickup rate of insignificant cancer, etc. Or if they're prepared to fund a PSMA PET CT, or if we can get them funded, because there will be ways around it for us as well in certain institutions, then that's a much better pathway. Half the men are not going to have a biopsy at all. Of the ones who do, it's going to be limited biopsies, and they're going to have cut the rate of insignificant cancer. So it has to be a yes for us, certainly here in Australia where we've got access. You're smiling. That's what you want to hear, isn't it?
Yeah, look, I think the trials, it's positive, right? It's nice that we don't have to, I think biopsy is a bit invasive. I know urologists probably don't think that, but it's an invasive procedure. And I think it's great that we've got a way of reducing it.
Yeah. So James, what about, we Jochen Waltz, our good mate Jochen, was doing the discussion today. So we haven't heard yet what Jochen said, but he's very, very smart on all this early diagnostic stuff. And I'm really interested to hear what he says. But what do you anticipate are criticisms, or we've been through reviewer processes with the paper, of course, as well. So limitations, let's talk a little about limitations or criticisms.
Yeah, I think there may be around the percentage with significant prostate cancer. When we look at the primary 1 trial, we probably expected to have about 30% with it, while we had 16% in the control arm in this trial. I think a good part of the answer is the different definition of what's actually significant prostate cancer. So we did we did weed out, I guess, all of that less than 10% pattern 4. that does explain the lower amount of it. I think it actually highlights also why PSMA PET is all the more important. It can really help to identify those who have significant prostate cancer, and there's a very low, I guess, percentage in this population. I think it actually strengthens the use of it. You can avoid so much biopsy and really just target for the men who actually need it. There's a lot of the later follow-up that we don't have yet. Obviously, it's an early readout. This was planned, but we are continuing to follow the patients for up to 2 years. And that will give more information around, for example, those who are PSMA negative and avoided a biopsy. They still have regular follow-ups, PSAs, and I'm looking forward to seeing what happens in 2 years, getting the final readout. A lot is embedded. I think, Renu, it's a very good point you touched on around anxiety for patients. You see it in clinic, and I think, and I've seen it with a lot of these trial patients. We'd call them, tell them it's a normal PSMA PET scan, and there'd be a sigh of relief. I think it does mean a lot to them. They can avoid, or at least, invasive procedures and reassure them to some degree.
And you did build in PROMs into this, and one of our co-authors, co-investigators, Hariana Dillon, health psychologist, so that's embedded in this. So is that data in this paper or coming subsequently about patient experience? Yeah,
all that data, brilliant work with collaboration with Hariana. That's all embedded for the final analysis. But we do have many PROMs around cancer worry, anxiety, decision regret down the track. So that'll be quite informative. And the other part is around health economics. I think we do have access to PSMA PET like we have tap water in Australia. It's I think that's one of the impressive parts why I like doing research here. So I think that having embedded that with the help of the ANZEP Below the Belt grant, we have Professor Richard Jabber-Lurenko who embedded health economics analysis, and that'll be a readout at the end as well.
Wow. And then one of the other questions that will come up is people will say, what about the quality of PSMA PET CT? How important is that? This is in a trial in a country where there's a lot of PSMA PET CT, but you embedded all the quality metrics. You're using primary score. There were central reads on these scans as well, or in a proportion of them. So how do you address people saying, well, we don't have that type of expertise, or we're not using... You're looking at Louise. Okay, Louise is going to answer this question. Or, if people in their own country said, yeah, this is great, how are we going to get our local nuke med teams to feel comfortable reporting intraprostatic findings? Because still that's not something that's commonly done around the world. It's mostly still a staging scan. As you say, primary score is an important way of doing that. But Louise, your thoughts on that, rolling this out to other places?
First of all, I think PSMA PET is not like MRI in terms of quality. It's easy to get a high quality PSMA PET. You just have to make sure that you image after 60 minutes after you inject. And you have a certified radionuclide PSMA PET agent that you're using. In terms of the primary score, it's pretty simple. We did a kappa scoring session when we were doing our validation study. We did a 1 hour scoring session with each of the investigators who'd never used the primary score before. And we had a kappa of 0.77 in that validation study. And James, what was the kappa? It was pretty high between the local and central read, huh? It was...
Yeah, it's a substantial. It was a 0.81. So it was very high. And a lot of these local readers didn't necessarily have very high experience. They did, have a training session, but the central review panel, we were 5 on the panel with Narja, Sid, Louise, myself, and Michael as well. I think that was, people with even very high experience versus those who have only seen a few. It was highly consistent, substantial agreement, yeah.
And the other thing I would say is the primary score has now been incorporated into lots of guidelines. And Nadia Sayadi, who works at St. Vincent's, has done a fantastic free online website called primaryscore.com. And it's an educational tool. So you log into primaryscore.com. It gives you a series of 10 cases. You get a score, then you get a whole series of cases, and you get scored again at the end. So if people, and there's a lot of podcasts in it, it's an explanation of it. It tells you exactly how to use the primary score and goes through a whole series of difficult cases as well. So that's free online.
And we'll put a link in the show notes to that as well, Renu.
Amazing.
Well, look, congratulations.
Congratulations.
I know you want to also give a shout out and thank your collaborators and funders and sponsors and so on. And we'll flash some of those up on the screen as well, James.
Yeah, thank you. No, we would like to thank especially Prostate Cancer Foundation, who funded 2 grants supporting this. ANZA for the Below the Belt grant, NHMRC, and the Curran Foundation supporting from St. Vincent, Sydney, as well as the Peter Mac Cancer Foundation.
Thank you. And Peter Mac were the sponsors of the trial?
Yeah, and Peter Mac were the sponsors of the trial.
From a governance point of view. Very good.
Fantastic.
And the statistics team were at Peter Mac, the BACT team, I think.
Yeah, and a big shout out to BACT. I think it was also a huge collaboration. I mean, this was, a team of well over 100 overall of collaborators. And BACT were just fantastic, especially getting this readout done so quickly. Sophie, Jess as well. We had Michael Fay and Emma Link who were helping with stats. So quite a big team behind this. To have these high quality results. Yeah, and
as Louise said, this was done on a shoestring, Renu. This is not like some big fat, pharma sponsored grant. This is another beautiful example of academics in Australia working together very collaboratively on a bit of a shoestring, Renu, or Louise, just like you did on the primary trial. So, let's wallow in that for a second.
Yeah, I mean, this was shoestring. It was funded from grants from St. Vincent's and from Peter Mac that we had. And so rather than waiting to get a grant, we decided to host straight in and try and do it on a shoestring in order to get it out in time. And it feels like it's gone on forever. But in fact, it's probably pretty fast for 660 patients. I think it was a good choice. Halfway through, it felt a bit hard. And one thing I really want to say is thank you to all the urologists, because what they did was randomize 660 patients. And that took, getting urologists to randomize patients every day in their rooms that's not an easy thing, right? So thank you to all the urologists who really invested in this trial and randomized 660 patients, and then did the right kind of biopsy pretty well 100% of the time. The number of violations that we had, and the urologists had to know so much about what was going to happen to that patient based on the trial. So great.
I love that when they talk nicely about urologists.
Yes,
thank you. We're usually getting criticised for stuff, so yeah. Yeah, I agree.
Very
great.
good.
And many of them are in the audience today and will be out on the town in London tonight having a beer with you guys. And it's really awesome. And of course, to the patients, James, lots of our patients really enjoy being in the trial. As you said, 1 in 10 of them, when they're randomized to the biopsy, said, I wanted the PET scan. But it was pretty good. We spoke to them. We prepped them very well. And I'm very grateful to all of our fantastic patients who participated in the trial.
No, it was tremendous. Them and their support group. Ned Van der Hayden also as the prostate manager. I think she got a lot. Well, I noticed you said that you felt it was a little difficult halfway through. I think I felt that quite a bit throughout the trial. Yeah.
Okay, it was difficult the whole way through.
Yeah.
Really.
Very happy to have it. Reading out today.
Well,
congratulations to both of you and the whole team.
Yeah, it's a big day, isn't it? Yeah, a big personal one for us who are very involved in the trial. So excuse us a bit if we're all wallowing in it. And very many of the authors on that list are regular contributors to GUcast and good personal colleagues and friends of both myself and Renu. So big congrats to everyone for Primary 2. Awesome day.
Yes.
A brave trial, as Louise memorably said on GUcast back in 2022. And a big day for us today, having it read out in the Practice-Changing Plenary at the EAU with a co-publication in Lancet Oncology. All right, that's all we have time for.
Here we go.
Great. Thanks very much to you, James. Thanks very much to you, Louise. Thank you for joining us and enjoy your night out in London. We'll be back soon with another episode of GUcast. Thank you very much.
We're going to enjoy it.